Good afternoon, ladies and gentlemen. We are calling the meeting of the Rutherford County Benefits and Insurance Committee to order. And the first item on the agenda is to approve the minutes of the last meeting. Do we have a motion for that? Ms. Barnes, and a second from Ms. Hickerson. Any discussion, changes, or additions? There being none, all in favor of that, please say aye. Aye. Any opposed? Now, without objection, since we have one of our distinguished members who must leave here at 2 o'clock, we're going to rearrange the agenda in its order just a little bit. We're going to skip the first sort of 4 review items and start with what is listed as number 6 on your agenda under the new plan options, since this is very important in our planning process for our budgets, both for all of us, county general, school board, etc. We are going to start there with our agenda if you don't have any objections, and we'll have the usual reports at the end. Okay, so Mrs. Stinson, you will lead us on this journey, and she's going to take us on a journey that could be a bit overwhelming as far as understanding it. So if you have questions, please feel free to enter into this discussion and ask her anything you need to ask her.
If you refer to the document titled New Plan Proposal inside of your packets, we'll start there. I have 2 new plans I'm proposing today. One is related to the dental plan, and we'll begin with that. We currently have 2 options within dental. One option provides for in-network benefits and out-of-network benefits at different benefit levels. Our second plan option in dental provides for benefits at the same levels, and there's a significant difference in premium of those plans. The one thing that is common between both of those plans currently is the orthodontia benefit. And when we consider our population and the number of families that we have, especially with young children within our population, it seems like it would be in the interest of our employees that we would offer a benefit that has an increase, or a plan that has an increased orthodontia benefit. So the proposal is to add a third dental option beginning with plan year 2000 or calendar year 2013 that has the same benefits as our current option 1, which provides a difference in benefit level between in-network and out-of-network, and raises the $1,000 orthodontia benefit to $2,500. In the event that someone has utilized, they are currently enrolled in a dental benefit and they've utilized a portion of that orthodontia benefit, there would be an offset. So I want to make sure the insurance committee understands that as well. So as an example, if someone does this buy-up option into option 3 and they have already exhausted the $1,000 limit in their current dental option, then the maximum available to them would be $1,500 should they enroll into the new dental option. But I think that this is a benefit that will have interest and will help support some of, just life's events inside of our population for our employees.
Now, Ms. Stinson, for those of us that don't know about all of these things, what about the rate structure on this? I mean, is it
right? So the rate structure will be 10% above current option 1 rates. Is the actual rate structure for this benefit. And we'll talk about rates a little bit later, and I can show you what that actually is. But typically, whenever you increase a single benefit, such as orthodontia, it's commonly known as a buy-up option, and so you would expect to pay a higher premium for that additional benefit on something like this.
Okay, other questions? And Mrs. Stinson, do you want us to address this one individually as far as the dental option before we go to the other discussion regarding the medical plan itself?
I think it'd be appropriate to go ahead and determine, the desires of the committee prior to moving to the medical, so that we can handle them individually rather than together.
Rather than getting this one into the other more difficult discussion, I guess. Okay, you've heard what she said about the dental option, that we're adding another dental option. And do you have more questions, or does someone have a motion that they would like to suggest for the implementation of this? Mrs. Hickerson.
Just for a little information, this dental plan strictly stands on its own. The county does not pay any money towards this. The premium is carried by the employee only. So all we're doing is basically offering a third option at no cost to the county's budget. 'Cause
Correct, there's no increase in contribution from the county to offer this plan to employees. Any rate increase would be absorbed by the employee.
Okay, then I'll make a motion that we approve this option 3 to have available for 2013 for our employees.
Have a second. Mr. Sandvig and others. All right, now discussion. There appearing to be no discussion. All of you then in favor of this, please say aye. Aye. Any opposed? All right, thank you. Now we just continue at this brisk pace. We'll move right along.
We hope. Okay, the next one is the medical. Not so long ago, a motion was passed to actually discontinue offering option 1 beginning with calendar year 2013, and I was tasked with finding a replacement for that. In doing so, I considered the feedback I've received from employees since coming into the county in June of 2010, and as well as I looked at what other offerings are out there for other government entities, particularly with the state was one. And in doing that, the copay plan is what has been presented to you, or what is being presented to you today. The copay plan is designed such that if someone goes to their primary care physician, they would pay a $30 out-of-pocket cost, a copay, and they wouldn't owe anything further. If they went to a specialist, they would pay $50. They wouldn't owe anything further. If they required hospitalization, however, they would then have that deductible apply. So the purpose of the copay plan is to help our employees make healthcare more accessible. Right now, with our current options that we have, they are deductible plan options. So someone in option 2 has to meet, unless it's preventative, has to meet that $500 deductible before they can receive care that is covered under the plan. And that alone is a gatekeeper for a lot of our employees. A lot of our employees, their budgets are very tight, and they will put off care based on the feedback that I've received, because they know whether or not they can afford $30 this pay cycle to go to the doctor. What they don't know is whether or not what that 20% would be, or what that deductible would be that they owe, and how they're going to fund that when the bill comes due. So they put off health care. It was for those reasons that this particular plan was designed, because I think it will provide us 3 very distinct options within the county. We'll have the copay plan. We'll continue with our current option of option 2, which will be renamed the deductible plan, and then we will also continue with our HRA plan. And I've provided you with an overview of what the copay plan would look like. So if you want to walk through that, just for in-network benefits, we'll use that as a sample on this. The annual deductible would be $750 per person, $1,500 family, with an annual out-of-pocket maximum of $3,750 or $7,500 for family. A multiplier of 2, meaning that $1,500 on the annual deductible doubled, is common as a multiplier. The office visits would then have the $30 copay that I referenced, with 100% paid after copay by the plan. The specialist would come in at $50 with 100% after copay. The urgent care, which is the walk-in clinics inside of Walgreens and those type of places, would be $30, as well as somewhere like Physicians Medical or Tennessee Urgent Care, those type of urgent care facilities as well. Preventative care would be at $0. This would be a non-grandfathered plan under healthcare reform. Our MedPoint clinics would stay the same for employees. Hospital care, as I mentioned, would be 80% after deductible. The emergency room would carry a flat $150 copay. The way it's written right now, there is a separate deductible unless it is deemed an emergency. Typically, that does not occur. That's just the reality. That is intended to be a gatekeeper that often is not assessed, because it's difficult to say whether or not the situation could be deemed by that individual as life-threatening at the point that they present. We do have an abuse of the emergency room within our population, as do most employers. Of our ER utilization, in the last reporting with Cigna, over 30% of ER visits were deemed steerable, which means that they could have went to a lower level of care, like an urgent care facility, and had their need addressed. So I think that in exchange for the copay plan and the premiums that would be structured, this is one area of responsibilities that we need to insist upon the employees taking responsibility for. So there is the $150 copay there. And then the generic, you can see on the prescription what the generic and the preferred and non-preferred is on the copays. Are there any questions about this? Do you all have an understanding of how copay plans work, or is there any questions I can answer about it?
On the example of the ER and the hospital care, if someone goes to the ER because they get sick in the middle of the night or whatever, and they are then admitted to the hospital, then does it kick into the hospital care and that $150 go towards that, or is it still separate? You pay $150 for ER and then the admission is a separate
Our visit would be separate.
Ms. Hickerson?
I noticed there's a note down at the bottom that says, could you elaborate for me, please, ma'am? The copay does not apply towards the annual deductible. Could you kind of explain that in a little better, please, ma'am?
So, right, so when I started, I gave the example of if you go to the doctor, you would pay $30. If you go and you're admitted to the hospital, you have to pay the deductible. That $30 that you paid at the doctor's office does not offset that $750 deductible. There's an exchange there. We're going to pay 100% after that copay, and the exchange is in the event that you need a service that is a deductible-based service, then you start at $1. And, you know, those exchanges are important to control the premiums inside the plan.
I was just curious about the preventive care, the zero copay, no deductible after the you talking about just like your yearly physical with blood work and stuff like that, or are you talking about things that once a person, say, has had a stroke or a heart attack, and then later on they have to go for a yearly specialist or something like that? Is that included in that, or is that separate?
These would be things that are typical screening and preventative-based services. Typically, when you've had an episodic event like that and you have routine diagnostics performed to see where you are in the stage of recovery period, then those are considered diagnostic and they would have other plan benefits applied.
Other questions? Now, how do we proceed from here, Ms. Stinson? You've sort of outlined this, and do you need to go ahead and attach with this the cost of this before we address whether we want to do this?
Sure.
Additional.
So in the at the very top, it tells you that premiums will be 5% above current rates for option 2. And there is inside of your packet a premium rates that shows you what the rates would be, but basically it's 5% above what our current option 2 rates are.
So on this premium page that we have here, is this option 3 that we're talking about?
No, sir, it's the option, it's on a different page. So currently, I'll give you the rates. So currently, employee, just talking about the employee portion, not the county contribution portion. Currently, for employee only in option 2, the cost to our employee is $40.19. The copay plan would be $42.10 if approved for the rate. The employee plus spouse is $84.40 currently. And if funding were to occur at the same contribution rate, then that would change it to $88.41. But we will be discussing contribution levels at a later time. Employee plus child is currently $74.35. That would change it to $77.89. Employee plus family is currently $116.54, and it would change up to $122.09.
Did everyone follow that? Do you see where she's reading those numbers from?
There is a page inside of your premium rates that looks like this. These are current rates.
All of those are the current rates for option 1, 2, and 3. Is that correct?
That's correct, sir. Ms. Harvey has a question, sir.
I just have a
Yes,
brief
Ms. Harvey.
question. On those rates that you were giving us, was that for everyone, or is that just the general Rutherford County employees, not the Board of Education employees?
Those would be for the county general. Of course, it's the same total rate premium. We just do a 10-month deduction on some of the Board of Education employees.
So over the course of the year, they pay the same.
Yes, sir. Ms. Hickerson has her. Ms. Hickerson.
Ms. Hickerson,
Question, if we do this co-pay option, this will be available for our retirees also?
Will be available for retirees.
So it's probably a good thing for them because they would know they'd owe $30 or $50 or $20 or whatever it is. It
Right.
would be a better, potentially a better option for the ones that don't see maybe high dollar
Their
claims or
income
something.
levels are down, correct?
I don't know if anybody else has any more discussions or we'll put something out there. I think it's a good option, since we did take option one off the table a couple of months ago, to offer something different, and this does let a person know that, yes, I have $30, I can go this week to the doctor, or my children can. I'll stick it out there. I'll make a motion that we add this option of co-pay option to our medical plan, so that we'll end up with the 3 plans, the HRA and deductible, and then the copay.
okay, do we have a second? Okay, Ms. Boney. Now, Ms., a bit of clarification here. What she's saying, and this may be the maker of the motion, this option that we're calling copay will be replacing our current option 1. Now, Ms. Barnes, is that what you wanted to say?
Just seconding the motion.
Oh, you were second the motion. Okay, good. Now, let me see if this is correct. This copay, we haven't actually said what the 2013 rate's going to be. We're just saying that these premiums will be 5% above the current rates. Are we going to have a discussion about rates for option 2, et cetera, before we get to
Yes, we are.
2013? Is that coming up today as well? That's
That would be
premium.
next.
That's next.
Right.
So all we're doing is endorsing this concept of this additional plan that we're putting in place. That's all that we have the motion on the table, and whatever rate is we wind up with option 2, this one will be 5% above that.
Well, this one would be 5% above current option 2.
Oh, okay. So that's good. So we won't, even if we change.
The rates that I read earlier already reflect that 5% above current option 2.
Okay, so even if we change option 2's rates, this copay rate will remain 5%
Right.
above, just what you quoted just a moment ago. Okay, well, that's good news for the copay people that choose that. All right, any other discussion? As soon as we're ready to vote on this, all in favor of this, then please say aye. Aye. Any opposed? Some may be uncertain. But anyway, all right, so we're moving forward with a replacement for option 1, and we're calling it the copay plan, and I don't know what the option number will be when she publishes. There won't be an option number on this. Okay, so that just took us through, that was just the new plan option discussion. Now you're going to talk about premium rates, is that correct?
Okay. First, I'd like to walk through the premium rate documents that you have in front of you. Just give you an idea, so as I refer to them in the conversation, you'll know better which they are, which ones are which. The first page is a revenue versus expense comparison. I'll discuss in a moment. The second is the necessary increase. The third gives you enrollment information. So as we're talking about rate increase and contribution levels, if you are curious about how many people are enrolled in a certain tier, you'll be able to refer to this page. The next page that has the red outlined at the top is the current rates for 2012. And then there are two premium proposals on the last two pages. The one in green will be what the original recommendation is on today. The one that has the pink highlights on them, or light red, depending on your vision, is what the rates would be should we decide upon an increase and keep the contribution levels as they currently are. Okay, so if we can go back to the very first sheet, which is the revenue versus expense comparison. For the last several years, we have held onto our rates. We've passed flat rate increases, 0 rate increases, with the exception of option 1, which took a significant increase 2 years ago. Last year, we knew that there was a need for a rate increase, but we felt like some of the initiatives that we had within the county would offset in our claims experience, and a decision was made to hold our rates flat for another year. This sheet shows you whether we made a good decision or a bad decision. So if you look at this, our total revenues in 2011, and this is calendar year, so this is a little bit different from what you'll see on financial reporting because that is fiscal year. We had $48,291,015.77, so that's what we took in. Our payout for both within our Cigna plan, our operational cost of insurance, our clinics, everything that affects our insurance plans, our expenditures was $47,991,615.08. So that is just $600 to the right side of the equation, you would think. Where you have to stop and say, did we make a good decision or did we not make a good decision, is when you consider what you all lived through, much more than myself, when it came to GASB. Within GASB, we modified the retiree benefits in order to offset our ARC, our annualized required contribution, and our OPEB obligation, the future funding of our retirees. And currently, that is over $1 million a month that we see in our ARC that we need to be funding based on our current population. So when you look at, we have, in order to sustain the effort that was put forth through the GASB 45 modifications, we need to be funding over $1 million a month into our OPEB, and last year we contributed $300,000. That makes those 3 years seem much longer than they probably already felt before, I'm sure, because I felt it, and I wasn't here for as long as you all were dealing with that. So I want you to keep that in mind as we have the next conversation about the rate increases. If you'll go to the next sheet, which has the yellow highlights in it, you will see that we made a very good decision whenever we decided to disband option 1 after this year, because it needs a necessary increase of 94.5% to sustain itself in 2013. What occurred in the building of the sheet was an assumption was made that option 1 employees would roll into option 2, which is why you see a recommended rate action of 20% there. Under option 2, the necessary increase to have revenue meet expenses is 28%. In option 3, what we discovered is that we're overfunding, and we know that because we've had discussions about subsidizing the other plan options. We're overfunding in option 3, 24%, based on projections. In the retirees, the current option 1 for under 65 needs a 43%. The under 65 option 2 needs 122%. We've had a couple of bad claims in that mix. Our over 65s are doing better than anyone else at only 11%. So that puts the task of looking at what is the tolerance level and what are we actually able to do. I've met with both finance directors to look at this to try to come up with what's the right strategy and approach. And the recommended rate action is what I am proposing in terms of rate actions on the plan. So we've already talked about the copay plan will carry a 5% increase over 2012 option 2 rates. Option 2 has a recommendation of a 20% increase, and we'll talk about what impact that means to our employees in the county here in a moment. Option 3, in order to offset some of the burden to the county by taking a rate increase, it's the recommendation that we drop the premiums by 15%. Since those are fully funded by the county, that will give the county some relief in terms of rate increases on other plan options. The under 65, a 20% increase is being recommended, and the over 65 has a 10% increase being recommended. In addition to those recommendations, if you will move to the next to the last page in your packet, starts with 2013 premium proposal. In addition, we contacted several counties, almost 10 counties, and asked what was their contribution levels. What does the employee pay in terms of the total rate, and what does the county pay? Most often what we see are two things. We see a 70-30, 70-25 type split. We saw 80-20 a couple of times. In a couple of areas, we would see they would pay 100% of employee, but only 50% of the dependent cost towards the premium. So in reviewing that, and the state has an 80-20 as well. So when you look at what is Rutherford County doing, and can we sustain it long term, it makes you pause and say that probably in order to sustain not only the needs of rate increases and the contributions, we probably need to start looking at what we are funding on a tier perspective. So if you will look at the sheet titled at the top, says 2013 premium proposal, employee contribution adjusted, 90%, 88%. The recommendation being brought today, in addition to the 20% increases and others that I talked about, was to change the contribution level on some of these. On the individual plans, we would maintain a 90% contribution. So employees only, we currently contribute 90%. It's actually 89.7, but for rounding, we'll say 90%. The employee pays 10%. Recommendation is to sustain that contribution. For employee plus spouse, employee plus child, and employee plus family, to reduce the contribution by the county from 89.7% to 88%. And what impact does that have? If you'll look at the sheet, the way to read this is that top says copay plan. So that's the plan that we just passed, and that gives the premiums of what the premiums would be for the employee. If you look at the second column, it shows what the contribution amount per month would be for the county. And those are county general in the first two boxes. In the last two boxes, it gives employee portion for the Board of Education and then the county portion for the Board of Education. Moving down the sheet, you'll see deductible plan, which is currently called option 2. You'll see that on the employee, the premium will move from $40.19 with a 20% increase applied. That takes that to $48.12. The county would pay 90%, the employee would pay 10%. That makes an increase for the employee of $7.93 per month. It makes the county's portion increase to $69.92 per month. And then the Board of Education is lined out as well. The Board of Education has a $9.51 increase for employee, $83.91 for county for the 10 months that they contribute. Employee plus spouse would move from a rate of $84.40 to $117.72 with an increased employee contribution of $33.32. For the county portion, it would move from $733.09 to $863.26 with a difference in premium of $130.17. The Board of Education for employee portion would see an increase of $39.99 with the Board of Ed contributing $156.20. We move to employee plus spouse. Premium would go from $74.35 to $103.71 with an increase of $29.36. The county portion for county general would be is $645.82, moving to $760.46 for a difference in premium of $114.64. The employee portion for the Board of Education would have a difference in premium of $35.23, with the county Board of Education portion being $137.60. We move to employee plus family. Premium would go from $116.54 to $162.57 for a premium increase per month of $46.03. The county general's difference would be $179.75 per month. Board of Education employee would increase $55.23, with the Board of Education contributing an additional $215.70 per month. In addition, on this sheet, you will see the adjustments on the retiree premiums. This was our last year to get the actual retiree premiums adjusted to where they needed to be. So you will see those increases that we recommended, with the under 65 being at 20% with adjustment where necessary, and the over 65 being 10% with adjustment where necessary. In addition to this, on the dental premiums, and I don't see this on here, I apologize, it must not print it off. On the dental premiums, our current option in dental needs a 2% increase. And I mentioned that the new plan would be 10% above current option.
Ms. Stevenson?
I have one question. I think when Mary asked the question, something about our retirees, would they be eligible for the copay? Is it only eligible to the pre-65? Okay.
Right, currently option one is only eligible pre-65, which is why I clarified to the mayor that, you know, it's a replacement of option one is the cleanest way to state that.
Okay.
Okay, she's got a spreadsheet here that we can follow, but there are significant changes in the dollars. So what's your feedback? What are your questions?
One other piece of information, if you're flipped to the last page, this shows you what it would be if our contribution level stayed the same. So the last page is laid out very the same as what I just gave you, but it's at the current contribution level. So you'll see that we're at 89.7% across the board versus an 100% on the HRA, which is currently option 3, whereas the recommendation is the 88%.
So the only difference in those two pages is they both get the 20% effect, but it's just in the
It's the split of the
split.
correct.
It doesn't. The first page is 88% for everything except the individual employee, and the second page is the same as it currently is.
Yes, correct.
But there's 20% increase applied to both pages.
20% and 10 on some. There's 10% increase on the over 65 on the retiree.
Over
and there's
65 on
and
the
there's a 15% reduction on the HRA.
Okay. Now, Mrs. Stinson, in the big picture of things, have you computed how many dollars this would generate that we could be applying for the, I guess you could say, for the reserves necessary for the GASB that we're trying to prevent, or at least accrue something that would be available for the purpose of meeting those future liabilities?
The reality is that even with a 20% increase, the funding is still minimal to none.
In other words, we're not going to, you said we've gained $300,000 in calendar year 11. Even with these increases, you're suggesting that the actual cost of medical care is going to go up in the neighborhood of what you've projected here, so we still won't be necessarily building any reserves.
So we used 11% medical trend rate. And if you look at that, the necessary increase shows that on option 2, we really need a 28% increase. So in order to fund GASB, you're going to have to get above 28% before you can even consider that you've done something to fund towards that arc. And the problem is that we have offset payroll for benefits for so long that it's going to be a couple years of steady increases year after year before we get to a level where our necessary increase will drop to a level that is low enough. Let's say it drops to a 5%, and we feel comfortable passing a 10 in order to have that additional 5% fund that arc. That's the reality of where we are inside of our insurance plan.
And maybe this is the question for both you and Ms. Nolan. With these increases, and we see it's an increase for each individual employee plus the county and county general. Ms. Nolan and Ms. Stinson, how many additional dollars will that require for us funding? And then we'll ask Mr. Sandvig the same question for the school board? Just for full disclosure.
Or my assumptions, and I'll just explain what my assumptions were, is I took people who were currently in option 1 and moved them to option 2. The largest pools of people, of course, is the sheriff's department. And I took 20% of those people who are in option 2 and moved them into the copay plan. Now, with those assumptions, it's about a $600,000 increase to the budget.
So county general would need $600,000 more dollars.
I will say that's my 600 is split between county general, ambulance, and solid waste.
Okay.
But
Now,
of course, the biggest.
Now, Mr. Sandvig, what is your best projection on what the school board's going to need?
I took the conservative route after playing with some things like Lisa and sticking at the same contribution rates shown on that last page in the packet and not moving anyone to the copay plan, $3.5 million.
You took the most conservative, so you haven't taken any of the other approaches. Did you even use the 88% number instead of the 89.7? So you did not do that.
No.
And Lisa did. So Mr. Sandvig's may be on the high side and Lisa's could be on the lower side a little bit. I just wanted you to get a flavor of what we're talking about here in the big picture, and in that we've sort of postponed the necessity for doing this for a number of years now, and at some point we have to decide how much do we want to do to get back on track a bit, to have this a more balanced approach.
You know, one of the things that I do is not only try to design plans and benefits that benefit our employees and the lifestyles and the needs of our employees, but also to look at the plans long-term from a perspective of keeping them fiscally responsible and healthy. Because at the point that we are not able to fund these benefits, our next step is to start carving out some of the benefits, to start reducing the benefits available to offset the premium increases. One of the benefits of the copay plan is that you can move a copay by maybe $5 and offset the premium increase that's needed. It gives you more flexibility. With the PPO plan that we're in right now, which is option 2, same thing as option 1, you have limited ability. You can affect deductibles, annual out-of-pocket costs, but that 80-20 is a pretty standard split in the benefits, so you're a little bit more limited in that type of plan design than you are in a copay design. The state, as an example, I believe they started in 2010 or 11 with their copay that I was looking at, and at least in 2012, they've already had to take an adjustment inside of the copay portion, so moving maybe a copay from $20 to $25. It just gives you more ability to manage a plan, and so I'm hoping that we can do some of those type of offsets in future years as well. We won't be as limited.
Ms. Stevenson.
So, just so everyone's clear that may be watching or listening, the ARC that we required or said that we were going to fund is $1 million per month, which would be $12 million per year. And based on this analysis, we got close to 300,000. And so with that being said, if we don't do something to maintain the viability of the program, it would be hard to assume that we could fund it for future retirees, right?
We'll have to revisit our approach.
And Ms. Nolan.
In the calculation of the accrued liability, any amount that we don't fund is carried over, and interest calculation is done on those amounts. So the accrued
Not just
liability
$12
grows.
million.
It just continues to grow.
We did do, I met with Ms. Stevenson so she could assist me in one area, and we looked at the premium increase on option 2. And taking the 20% increase with the 88% contribution level, really what does that mean to our employees? Using a $40,000 employee, On employee only, it's a 1.5% per month impact to their take-home. And correct me if I misstate anything. On employee plus spouse, it's a 3.5% per month impact. On family, it's a 4.9% per month impact on their take-home pay. And employee plus child is a 3.1% per month impact to their take-home. Is that correct, Ms. Stevens? Did I say that correctly?
That is significant. Now, Ms. Stinson, when you looked at some of these other counties, in other words, we're at 90, the county's putting in 90% and the employee 10%. Is that typical? What was your findings with respect to the other practices?
So as an example, Chattanooga is an 80-20 split. White House Utility District is 100% employee, 50% dependent cost. Brentwood's the same way. City of Memphis was a 70-30 split. Memphis Light Gas and Water was a 75-25. Kingsport was a 70-30 with a 17% discount for wellness being offered. And one other group was an 80-20.
So when we look at all of this in perspective, what you just said, our 90-10 appears to be the most generous of those that you've obtained data from.
That's correct, sir. But I think the other piece to it, though, is that payroll piece, and I think that's where the comparison comes in. Is you know, we may be funding currently at 90%, but proportionate to their payroll, you know, would a 20% increase on a family plan have an almost 5% impact on them? I mean, that's the piece that you have to look at.
Okay, Mr. Hall and then Mr. Gammon.
Kind of going on what you said, I was just thinking about as compared to, I mean, what the employees and stuff see as the value to them. I mean, I was thinking a piece of paper like this right here, along with whatever we decide here, whatever it is, but something like this, and highlighted for that employee, so they could look at it and know how it affects them, but also know that it's a 90%. We always feel underpaid, but all of us. But if you look at the county portion, another $12,000–$14,000 a year for a family, added to what I'm paying as a private person out here to get insurance and stuff. So I think if you explain it and the value of it, because it's a good plan. I mean, if it wasn't a good plan, the teachers would be on the state plan. And so it's a good plan, and whenever we're talking to folks about it, we've got to be sure that people recognize that it is part of a good job that's here in Rutherford County. So I know that, like I said, we all feel underpaid sometimes, but if you look at the portion that the county picks up on it over the year, it adds to what you might really make and really do, because everybody else out there that doesn't have that job is paying that.
One of the things that we will be doing this year, in light of the fact if the copay goes through all of the bodies and is passed, we will increase our open enrollment meetings this year and be working more diligently on that process, simply because that education piece is so big. We'll be using different strategies to get people more engaged in making the proper selection for them, because at some point it does become employee ownership of the process, and being creatures of habit, which I've referred to before. We want to get out there and do more meetings this year so that people select the right coverages that they need.
Mr. Gammon.
Mayor, I, of all people, as long as I've been here, appreciate and know that the insurance is great. It's as good or better than most of it we've seen over the years. I've kind of been out of pocket for the past year. I'm back, and the kicker is I'm going to have to reiterate again several things. One of them is the fact that it is appreciative. I know the employees do appreciate it. What they'd appreciate also, though, is the county commission sticking with the pay plan and stick with it. They know, whenever you figure these pay plans over a 5-year period, 10-year, you know how many employees are going to be on your payroll within reason other than newbies coming in. But there's an attrition rate on top of that. When you sat here and started a pay plan in 1995, you changed it 5 times with the exception of what we went through the last few years. That's understandable. We know we have to pay into this. We know that there's a cost in there. But it would be a lot more easy to swallow if they would stick with a pay plan and these people could absorb these hits like this. This day and time where gas is going up and everything, and I know we all know this, I'm beating the drum, but some of these rate increases in here I know they're needed, I understand it, I've read it. There's no doubt that we're going to eventually go probably to a 20-80%. I mean, that's coming. I mean, it's going to have to. I still don't know that I agree with the Gatsby idea, sorry. That's just my thoughts on it. But if we do push this through, you know, we don't know if the employees are going to get a raise this year or not. And a lot of that's going to affect them in a lot of ways. It may not affect me as much as it does one of our employees and other employees that are making $25,000, $30,000 a year. You know, $50 to me, it's money out of my pocket, but it's probably more like $200 to some of these employees that make that money there. Now, the question I'm going to say, and it's not a proposal at this time, but I would make a recommendation if we have to go through with this, which we probably will, that we break these deductions down into twice monthly rather than just one. That way it can be absorbed a little bit better if that's possible.
Nolan sort of shrugged like we could probably do that. What's your take on that? You think we could probably manage that? And Mr. Sandvig?
Attempted to do that for our hourly staff when we first went to employees, and at that point, because of our weird payroll status for our 9 and 10 month employees, they had great difficulties, and we pulled back. They basically said we couldn't do it. So we
so
had
that
to
was
work on that. Cigna and employees.
It might be a bit of a difficulty. We might have to do some little bit of work, but points well taken, and we will consider that, assuming we move forward here and at some point and see if that's possible. Okay. Ms. Harvey.
I agree with what he said about the increase being a big hit. If I'm looking at this right, like a Board of Ed employee for family would have a $55 increase if we went to 88% a month versus $27 increase. Is that correct? So we're talking about $550 versus $270 a year. Okay. That's a big difference. Big difference.
Hickerson.
Well, I've looked at this, and I'm going to say it anyway. We laughed earlier. We've been looking at this for a long time. I've been an employee for 17 years and on this committee ever since then. We've seen that we're going to have to take increases, and I've said it each time, take a little at a time so that we don't, 2 years out or 3 years out, have to take a huge hit. I realize that this is $46.03 a month or $55.23, depending on Board of Ed or County General. But if we don't do this, our plan is not going to have something in it that somebody needs. We'll have to take something out, and we're all the time having appeals meeting, or our plan has the ability of having people come and say, look, this really would help me, but when we research, there's actually other people it helps in the plan. So we're able to adjust our plan. But if we, as an employee, me being one of them, doesn't step up and say, okay, I'm going to have to do this, something's going to be took out, and then there won't be as a good of option that we can compare our teachers to the state plan, that we can keep our teachers with us. And I realize $46 and $55 is a lot a month, but we have to make our sacrifice. If our car breaks down, we have to make our sacrifice not to do something because we got to have our car to get somewhere. Well, we need our health insurance to be able to get to work, to have the car to get somewhere. So, and with that being said, and then wanting to do the twice a month deduction, the way I set our payroll up out at the highway department is half of my insurances that my employees have come out of their first payroll check. The second comes out of the second check of the month. So they're able to already know this is how much I've got coming out. So they know the first check of the month is going to be bigger than the last part of the last check of the month. So if you throw it in there where you're wanting the health insurance took out of both of them, I realize there's 2 months a year, we get 3, but out of both of them, potentially on my few 65, 70 employees I have, that can affect them drastically because they pay this at the first of the month and this at the end of the month. But I've said it all along, we need to do a little at a time. And I remember years back, we actually said for an individual, the county would fund 90-10, and for a family, that's before we even went to the 4-tier, would be at an 80-20. We're nowhere near 80-20 when we set this many, many years ago and meetings ago. So I really think that, and this is affecting my pocket, that we need to go with the 88% funding by the county, or yes, by the county. And I say we look at increasing the percentage by 2% each year so that everybody already knows I'm going to have an increase next year, and not are we, they'll already know, until we get comfortable to the 80-20 split or the 85, but we need to get comfortable, and we need to just, we draw the line in the sand for the Gadsby and cutting the deadlines and the dates of hiring. We need to do it with this. I'm going to stick it out there. I'll make a motion that we do the 88% funding on the county's portion and do the required 20%, 15%, and then all of the percentages required for the retiree increases on the premiums.
Okay, Ms. Hickerson,
I need a motion on the dental as well.
and would you include in that same motion the 2% increase on the dental?
Yes.
Okay.
And then the buy-up option would be 10% above current option 1.
And the buy-up option on the dental is 10% above the current plan. So that part of your motion. Now, can we get a second? Commissioner Jordan. Now, Mr. Gammon, do you wish to say something?
The only thing I'm not sure if I got all that. I still was curious where we at on the bi-weekly as far as splitting it up where you can. It may be that I'm not sure if the school system can do it, but there are employees that can. I'm not trying to nix them in any way, but if you can't, there's no sense of everybody not being able to do that division. So I would like that to be included somewhere in this.
Okay, excuse me, Ms. Hickerson, would you make the motion that all of those departments and agencies that could, in a reasonable way, implement the deduction every paycheck or twice a month, allow that to happen? It's not mandatory, but we make every effort to make that happen. Is the maker the second okay with that, whoever that was? That was Mr. Jordan.
Like that gets down to the mechanics of it. That's between the payroll and administrators.
Yeah.
I mean, I would think that would just be a staff work to work that out. But I'm fine with the second on that motion.
Okay. As long as they have the flexibility just to use their best effort. Mr. Sandvig?
Lisa and I were talking, and think back. One of the possibilities we discussed was setting up a separate hourly payroll for the board for 12-month employees. And if we had that, if we didn't have mixed 10 and 12, it's probably doable.
Okay. Well, we're going to give you all the flexibility you choose to exercise to see if you can do that. Okay, other discussion. Did you want to say something, Mr.? Okay.
That's good.
Other discussion. We'll see if Ms. Anderson got that down. They want to know if you can read back what the motion actually says, please. Read the motion back to them.
I'll try. It's in bits and pieces. Mary recommended to move the funding level from the county to 88% with the required increases to the medical premiums of either 20%, 15%, or 10%, depending on the plan. To also include the 2% increase in the dental premium and the buy-up option of 10% above the current plan, and also include all departments and agencies to implement the twice-a-month premium deductions on payroll if possible. Did I do it?
That was good. If Ms. Hickerson and Mr. Jordan will allow us to say that the employee portion, just for clarification, will remain at a county of 90% participation. And the other components are the ones we're removing to 88%. Is that okay, Mr. Jordan? All right, now, so Ms. Anderson can add that in there so we be sure we're clear. Ms. Boney?
How are you going to get this across to the retired people? Make them aware of these changes?
I'm sorry, could you repeat the question? I couldn't hear you.
Make the retired people aware of the changes? Who's going to explain it to them?
Typically what we do is a mailing, and then they will call in and speak with Evelyn if they have any questions based on the mailing that they've received.
Okay, and Ms. Hickerson?
Now, it's my understanding the increase that we had on the retirees portion, I'm not trying to be ugly about it, but it was to be expected because we're at another step to have an increase to get them to the funding.
Part of it is, but part of it is a rate increase as well.
Right, okay.
Correct.
Okay, other discussion? Ms. Stevenson?
Just to clarify, those that are under 65 would be available to go into the copay plan because that's another option that would be available to them.
And that was clear, we hope, in our original approval of the copay plan.
Mr. Mayor?
Yes, sir.
I
Mr.
would just
Jordan.
like to say how much I agree with what Mr. Hall said a while ago. I mean, there's so many people out there that are self-employed or in an occupation don't have insurance, and it's a cold world out there. And if we don't do some of this stuff now, and I don't by any means take it lightly, taking more money out of these employees' paychecks, especially in the economy it is that we're in. But if we don't do some of this now, these small pieces at a time, we're going to be here in a year or two making wholesale changes or just clobbering somebody with huge increases. So I don't like these increases any more than anybody else, but we've got to keep this plan sustainable and healthy, and I don't see any way around this. We could not do this, be here next year doing them twice as much at once at that point in time.
Thank you very much, all of you. Any other discussion before we have this vote? All of you in favor of this, then please say aye. Aye. Are there any opposed? Mrs. Harvey, let the record reflect. I'd like to say, on behalf of myself, and I'm sure all of you too, that it's pretty remarkable that Ms. Stinson has presented this information in a way that we can follow and understand and in a clear fashion, and it's very helpful as we've had this difficult discussion.
Mayor?
Yes, Ms. Hickerson.
I'm going to put it out there again to save us from the headache. I'd like to make a motion that we do a percentage increase, or ever how you want to exactly word it, each year annually until we get to the point of 80-20 funding, which was something that was originally planned many years ago, 3 insurance directors ago. And so I'll put it out there that we need to look at doing it, because we keep talking about it, that we'll revisit it, and then 2 and 3 years later we don't have an increase. I'll make a motion that we do a percentage increase annually, even if it's just 1% or 0.5%, till we get to the point of an 80-20 split on leaving the employee only at 90 until otherwise decided, but get the what I call family, employee plus spouse, child, or family, to a true 80-20 split, or so that we're actually in a better field with the other counties and municipalities around us.
Ms. Hickerson, do you want to make a specific percentage each year that we should consider? There's or do we want to just say you want us to consider this every year at a continued reduction? Do you just want to set a principle in place, or do you want to set a target?
I mean, I'm up for setting 2%, but it needs to be, to me, set in stone that next year, come April, May, March, whenever, that everybody's going to be aware that we're going to see the premium rates and here's what it is, so that our employees can plan that each year I'm going to have a rate increase to a certain point. I mean, if we want to just do 1%, so it's not such a hard sell each time, but it needs to get there.
And again, I'm sort of putting out, we're sort of discussing before we even have a second, where we're sort of trying to craft something that might be something that we could actually discuss. Is this 1% you're suggesting would be a 1% contribution from the county would be reducing 1 or 2% from next year? It'd be 87%, plus we might still have on the table some required increase just because of what has happened in the increase in cost of medical care. So it would be both things still being on the table. The county participation would reduce a certain percentage each year until you got down to 80-20, to 80% contributions. All right, so now I've asked you all those questions and twisted your emotion around. Do you want to make a point of clarification or just suggest that we reduce it 1% at a minimum each year?
We'll do a minimum of 1%.
All right, now, so we've got a motion on the table. Does anyone wish to second that motion? Mr. Sellers is a brave man. And all right, so we have a motion to second. Now we can have a discussion. Mr. Gammon.
Mayor, I'm going to, passionately, I know where Mary's coming from, and I agree. I said a while ago that I know it's going to get to that point. But I still think that we have to consider the situation that if you do these kind of increases, it's that in stone, then let's set your pay plan in stone and don't touch it again. There's no guarantees. That's the whole point. We can sit here today and vote on everything we want to, and next year come back and change everything we did. I mean, I've seen that. So when you start telling employees, yeah, they can get prepared for it, but I guess they're going to get prepared for the $5 gas increases. They're going to get prepared for this. When you go to the hospital, you got to pay $700 deductible to get a colonoscopy on the front end, and that's great that you got insurance to do that. There's people that doesn't have insurance. I understand that, but there's got to be some responsibility all over around to the public, but also to the employees on this. And it's just, I just don't think it's fair to etch that in stone that way. Now, I'm not going to say every year we shouldn't look at it, because I agree that it's going to have to get to that point. There's no guarantees. And again, that's where I come back on gas. There's never a guarantee. There's just not. But I just think we still got to consider the fact that employees have gone a good number of years whenever money was pouring in this place without a pay raise.
And Ms. Hickerson, again, not to dwell on this, but maybe your motion said we will consider at least a 1% reduction until such time as we reach the 80% level.
The word consider, we've used it for many years.
Okay.
Another I told you so. We do this each time, and I realize that, and I realize the choices of having to make this increase. And if we only do 1% and nothing changes next year, it's only going to be a $23 increase per month on me. If some wild chance nothing changes. But the thing is, I have to tell. I put it very plainly to the guys and to myself. I drink cold drinks. I eat candy bars. $46. I don't get two 12-packs of a Coke for for the month. You have to break it down like that, because there's something that everybody is doing that we don't have to do one time a month or whatever. And so, like I said, we consider it all the time, but we need to, because if not, yes, we want to etch this in stone. Well, if we don't, in 2 or 3 years, we're going to come back and take something out. And I mean, I like the plan the way it is, and we may still have to take it out because of the cost of medicine and doctors and everything just goes way high. But we don't need to take it out because of our employees not stepping up a little bit. I mean, it was mentioned that we have a slight abuse of the ER. Well, that drives that cost of our plan, that part of our plan up, when they could have went to another care that stays open later. So I want to see it in stone. I just, mine is not to consider, mine is to do it each year.
All right. I appreciate that. And your motion basically says that we will adopt the philosophy of each year reducing the county contribution by 1% until it reaches 80%. I don't know technically if we can encumber and future commissions to that unless I think we'll have to vote it in every year and approve it. I think we can say this body here endorses this concept, and we're going to adopt that concept unless something else happens otherwise, and then it'll be up to the commission to actually approve it. Of course, like they have to approve everything we do here anyway. Mr. Jordan.
I have a question. If we approve this motion, does it stay within the insurance committee, or does it go to the full commission for the commission to endorse it, or is that just a policy of this committee, and then next year we take our recommendation to the full commission? Because like you just alluded to, the commission isn't big on setting rules for 6 or 7 years down the road.
I think it's sort of made it, this body is making it its philosophy that next year we will bring before the Board of Commissioners that 1% reduction in its presentation for next year's rates, 2014 rates. We're talking about 2013 rates now. When we get ready to set the 2014 rates, I think we're seeing that we're going to send forward something that has a 1% reduction in it, plus whatever increase has been in the normal medical care cost increases to the commission for their approval of those rates. That's sort of my take on how this would really work. All right, Mr. Hall.
I was just curious, is there any way, she was talking about hers is $23. Is there, well, I don't agree 100% both either way on it, but I'm just trying to, with the information that we have here, do we know what 1% would be to the employee, what 1% would be to the county each year, so we could put it in dollars and say, like we have here, where we know that an employee plus a child is $14, or something like that. I mean, I agree with the whole principle of what she's talking about, that we've got to get there, and 1% a year seems like it might be something that's doable, but I really am just curious about what's the exact numbers it's going to cost an employee each year.
So county general, just for simplification, I can do both if you want, but Ms. Hickerson said $23 on employee plus family under the deductible plan. That's actually 2%, so it's only half of that. So you're only looking at $11.50, if my math is right, because you're only thinking 1%. So assuming that our cost stayed flat, which is what Ms. Hickerson started out saying, assuming that our cost stayed flat, and we needed no rate increase for next year just because of the cost of our program, then a 1% would mean a $12 impact to employee plus family under option 2.
Okay. Well, that puts it in a much better perspective. I mean, it's not as much as we thought, but it is still
But the reality is that probably won't happen. You're going to have $12 on top of a rate increase, because we've needed rate increases every single year, but we have not taken them as an offset to payroll.
Okay. That being the case, I mean, we're not, we have a motion and a second that we, this body, adopt as a matter of practice that when we renew annual rate structure changes, that we will include the reduction of the county portion by 1% until we reach 80%. Now, any other discussion? Do we need to call a roll or take a vote? We'll see. All right, we're just going to take a vote, and then we'll see if we need to, if it's too close to call. All of you in favor of that, please say aye. Aye. How many are opposed? All right, hold your hand up so I can sort of count. Well, we got 4, and let's see, some of these are not voting members, so those of us that are voting members, let me see how many of us there are. Y'all can put, the others put your hands down. 1, 2, 3, 4, 5, 6, 7. The ayes. I want the aye hands up. 1, 2, 5, 6, 7, 8 to 4. Let it reflect that it did pass with some good, careful discussion, 8 to 4, and we will certainly keep that in mind and make note that this still will require every year us to do this, and then we'll have to take it forward to the Board of Commissioners for their acceptance. So it's not locking it absolutely in stone, Ms. Hickerson, but it's putting us a little step closer. Okay, Ms. Stevenson.
I want to say thank you, Mary, for having the courage to throw that out there. And then also to thank Melissa and her staff. They put a lot of time and effort into coming up with and looking at different plans so that we can continue to have this benefit. And it's not always easy to come before a crowd, before the televised audience, to bring something forth that you feel like wouldn't be favorable in everybody's eyes. And I just want to thank them for that, because it is hard. But sometimes you just have to do the right thing because it's the right thing to do, not because it's easy. So I just wanted to thank her and her staff for that.
Okay, well, we're going to go back to the beginning of our original agenda, and Ms. Stinson can tell us about the financial status.
No matter what this says, we already know we need a rate increase, so this makes this part a little bit easier today than other months. Okay, so if you'll go to Fund 264, we'll start there. For the month of February, our per employee per month was $684.54 compared to same time of prior year, $529.28. When we add in our clinic experience, for the month of February, our total per employee per month insurance plan cost was $714.23 compared to same time prior year of $561.87, for a increase of 14.4% over prior year. Questions?
Okay. No questions on that?
I'm ready whenever. Okay.
Do we,
I'm sorry.
do we have to
If
do
you're,
anything on that?
if you will go to Fund 266. Our year-to-date is $785,204.87. For the month of February, our payout was a little higher than what you see in prior months. It's $325.412. Majority of that, it was 80-something%, was a workers' comp claim. So it was an old workers' comp with open medical that we paid on. Only 10.3% was the actual OJI payments within that $300,000. Compared to year-to-date, we were at $604,778.02. We currently have 19 worker comp claims still open.
And some of those will continue on forever with the medical portion of them still being, us being responsible.
Correct.
Any questions on either of these reports from Ms. Stinson? Ms. Anderson, do we need to do anything on those or just accept them?
No, sir, we just.
Okay, so we don't need any official action on those, so we will now have our workers, let's see now. Yeah, we're going to get the status from Mr. Good on the workers' comp and OJI.
Good afternoon. For the month of February, we had a total of 18 accidents requiring medical attention, and as you look at your report there, you'll see the breakdown of how that occurred. For the year-to-date, being January 1st through the end of February, we had a total of 26. Total OSHA recordables were 23. 11 of those injuries had restricted days, 2 were lost claim days, and then there were 10 others. The next page, if you look at that, you'll see the comparison of this year as compared to the 2 previous years, and we are down the first 2 months of this year as compared to the last 2 years. On the next page, you'll see that the total dollars incurred for the month of February was $29,750. And to break down those claims for you, the Board of Education had a total of 12 claims. Total incurred dollars for those claims were $19,180. And for the County General, had a total of 6 claims for $10,570. And on the next page is requested once before to break down those county claims into where they are in the county. Those 6 claims, 5 of them were in the Sheriff's Department and 1 in the Agricultural Department. You can see the breakdown of those claims. And that's all I have as far as my report.
Any questions of Mr. Good? All right, thank you, sir. Good report. Now, Ms. Kelly Perrion will tell us about wellness, and while she's coming forward, we would like to congratulate her. She has passed the Certified Nutrition and Wellness Consultant examination, and she now is Certified Nutrition and Wellness Consultant. So, Kelly, we appreciate and congratulate you for taking the individual initiative to continue to improve your professional expertise, and we're just thankful that you're here with us.
Thank you. I'd like to talk about the wellness report. The first quarter is listed. We have wrapped up our HRA drive, and we're really happy to have 241 participants. That is over double our last year's participants for our HRA drive, so we're pleased with that. One of the changes that we made were we had the HRA in clinic instead of coming to the individual departments. It was a change that seemed to help. So we are happy with the participation of that. We did do a drawing. You may remember our incentive was 8 free gym memberships to the MTMC Wellness Center. The names of the drawings are listed at the top, and they will be published in the next Safety and Wellness newsletter. Our diabetes support class concluded with 25 people completing a 5-week session. We had 27 people at Heart Healthy Lunch. Our cooking class for Fast Food Makeover had 28 participants, and just listed some of the wellness discounts that we made available for the first quarter. Our upcoming activities, we have a stress management dinner and discovery in Smyrna at Stonecrest Hospital on April 10th. Our healthy cooking classes, Healthy Asian Stir Fry on April 24th at the Health Department. And we have set up 2 mobile mammography days, one at Blackman's Clinic and one at Stewart's Creek Clinic, and an angio-screen mobile unit to come to Blackman because of our preventative health screenings were down last year. So we're trying to encourage that employees get their preventative screenings. So we have those scheduled for May 3rd, 4th, and 7th. Anybody have any questions? Thank you.
Thank you very much. We have one other item here, the clinic review. And Ms. Stinson, are you leading that discussion?
Yes, sir, I am. If you refer to the packet that says Walgreens Take Care, on a quarterly basis, Walgreens is provided, or Take Care is providing me with a rather extensive reporting that shows me what activities happening in the clinics, what type of conditions are being treated, and I've provided you with a subset of that information. I'm very thankful for this information. I've not received quarterly reporting like this in the past, and so this will help us to better understand what the needs are within our clinics, what we are treating, what the appropriate levels of treatment are, and how we can better serve our employees through the 5 clinics that we have here in the county. So if you'll move to the executive summary, one of the things that we did both through the RFP process and the implementation of Take Care is to look at what were employees' responses to the last survey that was completed regarding our on-site clinics, and can we address some of those things. We have addressed several of those things through the months of September to December within our clinics, and some of those are reflected here in this report. So if you read through there, we opened 4 out of the 5 of our clinics, you've heard me say before, on September 1st, which was a tremendous undertaking. We provided flu vaccines at the Employee Appreciation Day, plus we set up our flu vaccine clinics. Rather than going out to different locations, we did them within our clinics, and we saw an increase in utilization by our employees. And we've seen that again on our HRAs, so we may be on to something in terms of how we offer services. Some of the other higher points here, the designated specific hours for a walk-in, we have full-time now at Stewart's Creek for walk-in. The designated waiting area at the health department, we've been able to accomplish that. We've added the prescriptions medication, which was a survey issue at the health department. Number 10 is probably where we have seen the most addition of services. The feedback would state things like, I need to be able to call in to get an answer to a question without having to schedule an appointment. I need to be able to call in to get a medication refill without having to schedule an appointment. And you will see there that we have done those things, as well as we've developed a callback list. So because we call and confirm appointments 24 hours in advance, and we require cancellation prior to 7 a.m., we keep a callback list. So if someone calls in, there's not an appointment available, they can actually call and fill those spots. So we don't have those open appointment times that we've had in the past that are a cost to us because of labor costs. The dedicated clinic staff, I am hearing more and more success stories about how we are able to treat our patients at a different level because they can always schedule with the same provider at the same clinic location, which is something new since September 1. If you will go to the next page, I'll just give you a quick overview of what the program is trending like. We've seen over 1,900 unique patients. We've had many more appointments than that, but as far as individuals coming in at least once, we've seen over 1,900. Many, as we know, go in multiple times to the clinics in that 4 months. We have achieved a 16.7 penetration rate. We are continuing to see provider visits increase. Provider visits are your physician and nurse practitioner appointments. We've seen a provider penetration up to almost 15%. Our ancillary visits, which is really one of our bigger areas that impact utilization in our clinics, are increasing. So that's lab draws, lab-only type appointments, those type of things. The top diagnoses are acute respiratory infections, hypertension diseases, and preventative services. If you go to the next page, which is the net summary savings, I think this is beneficial in terms of allowing us to see, what are we really offsetting cost inside of our plan? So what this says to us is that total, if you look at direct cost avoidance, they're coming in at $708,000 based on their calculations. The additional direct cost avoidance, the referrals to the specialist cost avoided, the total emergency department cost avoidance, the inpatient care cost avoidance because we're able to get on top of a situation quicker, comes an additional $68,000. The indirect, that's where we calculate some of those soft savings that we've never been able to capture before. And the accumulation of all those comes into just a little under $150,000. And there's more explanation provided further back in the reporting that we can go through. My main purpose today is just to show you what is now available to us in terms of reporting in case there is a particular area of interest within the insurance committee for our clinics. Facility utilization, you can see how we're trending on our total encounters, which would be the appointments to the clinic, originating at just slightly over 600 and coming in at 1,000 in December. The thing to remember too, this does not include what is called care visits. Care visits are all of those things that have to be done inside of the clinic where the individual is not physically present in the clinic. So we get a call from the pharmacy for a prescription refill. We have to call and make a referral for a specialist. We're answering questions within the clinics, either through email or through phone calls. Those are still related directly to patient care, and they are doing over 600 a month in those type of services as well. And you'll see how we're trending on both the provider visits and the ancillary visits inside of our clinics. You'll see that since inception with Take Care, we've seen an increase in the number of specialty referrals that we've needed to make. So using the guidelines that Take Care has, determining when is an appropriate transition point has been a major focus since they've taken over the clinic since September 1. So you have an uncontrolled diabetic patient at the point that they can't be stabilized with staff in the clinic, they require a higher level of care, they'll be referred out. Mind you, we are not treating just stuffy noses inside of our clinics, as you've heard me say before. We have people presenting in full cardiac arrest. We have people presenting with mental health issues that need to be addressed. There's some significant disease processes coming in the doors of our clinics. So this type of reporting is very valuable to us in terms of just identifying. I know Ms. Stevenson and I have already worked on the mental health issue to identify what is the real needs out there of our employees, and are we meeting them in the health plan and in the clinic, and what other adjunct needs are there that we need to fulfill for employees. You'll see that we've had a tremendous spike in the number of lab procedures. Moving on, the demographics won't surprise us at all. We show that females represent 61% utilized in the clinic. The encounters by age category, to me this is valuable because it tells us what is the utilization of our retirees possibly versus our active employees. When you start, you have to make some type of calculated guess when you read this to understand, what is it? Are we getting young kids in? Are we getting, our average age employee in? What is it that we need? Because some of those things will also drive what the needs for those individuals will be. Unfortunately, the older we become, the more needs we have, and so that helps us to better gauge and monitor those things as well. As you can see from the report, our average or highest utilization category is the 50 to 59 age range. The diagnostic categories that we're seeing most commonly is the general symptoms, including the headaches, cough, and fatigue, the flu vaccines, which is not surprising given our flu clinic, the preventative services, including screening for hypertension, diabetes, our GYN services, our routine medical exams, hypertensive disease, and hypertension is one of the processes that we're treating most commonly, respiratory infections, and then the demographics, it shows here as the top 5 being the 30 to 59 contributing the most towards those disease processes. The final pages here are basically just the detail to the net savings that I referenced earlier. So page 10 and 11 gives you more information on that. It shows that, the reduce in the different types of visit. We calculate an hour and a half per appointment time per employee using an average salary wage, which I received from Ms. Stevenson against that. So, there is, these aren't just ROI numbers, which ROIs can be smoke and mirrors sometimes. You can really adjust those numbers sometimes the way you want to. There is some validation to this that we see. If you move on to page 12, I just want to point you to a couple of things. One of the things on here as an example is the needle induction services or labs. One of the things that I find that I'm educating employees on a lot in terms of how to lower their out-of-pocket cost, and it's also beneficial to our health plan, is if you have labs that your doctor that is not associated with the clinic routinely prescribes, you can go to our health clinics and get that lab drawn. So if my gastroenterologist wants a routine lab drawn every 3 months, I have him write me an order for that. I go give it to the clinic. The clinic can then draw those labs every 3 months, send the results to my gastroenterologist. What that does is it lowers my out-of-pocket, and it lowers the plan's out-of-pocket, because if you go to a private provider to have that, they're going to charge you for the needle induction on top of the lab itself. So there are other ways that through education that we can control our costs, which leads me to one other comment. We, as part of the RFP process, a full-time wellness person was included. And that wellness person will begin in April with Take Care. She will be in partnership with Ms. Perrin, and we will be able to ramp up our education and our availability of these wellness individuals within our population to drive some unique programs. I know that at Thurman Francis, as an example, they recently contacted us. They wanted us to do a monthly weight control program for them for a period of time to see what the impact is. And now that we have 2 people in April, we'll have better availability to be able to go in and do that and to use some of this reporting to identify what other areas we can address through those ladies. And then the last is just the most frequently seen primary diagnostic categories. And again, I just really wanted to provide this to you today so that you could see what is now available to us. And if anyone has interest in a specific information about the clinics, if you're letting me know in advance of the meeting, I'll be glad to prepare that. But I can tell you personally, I feel better armed to manage the clinics from a county side in terms of understanding what is going on inside of our clinics, what are we treating, what are the needs, how can we meet those both within the clinics and within our private health plan.
Any questions for Ms. Stinson on this report or any of the other reports that we've had? Does anyone have any other business they want to bring before this committee? If not, thank you very much, and the meeting is adjourned.